Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. The following brief lecture was delivered by Dr. Saad Mahmood. Dr. Mahmood is System Director of Cardio-Oncology at St. Francis Heart Center and Catholic Health Services of Long Island in New York, in the USA. Here he discusses some key insights into the cardiovascular impacts of CAR-T therapies. This talk was given as part of our 2025 board review course. In the show notes, you'll find a link to the full course, including modules on the management and detection of cardiac dysfunction, the toxicities of traditional therapies, hematology, and immunotherapy. I know you're really going to enjoy this portion of the course.
So we're going to talk about CAR-T therapies and cardiovascular effects of CAR-T therapies. These are my disclosures. The objectives are we will understand the fundamentals of CAR-T. We will recognize common adverse events after CAR-T. We will explore cardiovascular effects of CAR-T. And we will learn to apply clinical strategies to manage CAR-T cardiotoxicity, keeping in mind the data that's available to us, which is both retrospective and prospective. There's going to be two questions at the end. I'm not going to go into them with the answers, but things to start thinking about is which of the following are toxicities associated with chimeric antigen T-cell receptor therapy, heart failure, arrhythmias, myocarditis. And the next question would be, during CAR-T cell therapy, which of the following strategies could be employed to mitigate the risk of cardiotoxicity? Is it cardiovascular risk factor management and optimization, continuous cardiac monitoring during treatment, pre-treatment with steroids, early use of tocilizumab, etc.? Okay. So let's jump into our first objective, understanding the fundamentals of CAR-T. And, CAR-T is the first FDA-approved cell-based gene modification therapy. The CAR, or the chimeric antigen receptor, is a synthetic receptor that redirects the T-cell specificity towards the tumor-specific antigen. And this nicely illustrates how a chimeric antigen receptor is constructed. There's a single chain variable fragment. Then there is a spacer and transmembrane domain. And then there is an intracellular domain, which is a co-stimulatory domain, either CD28 or 41BB. And often we just think about the CAR in terms of what it's targeting, CD19 versus BCMA. But actually, the co-stimulatory domain is very important as well, because it actually leads to the amplification of the T-cell signal. So how is CAR-T manufactured? All the FDA-approved CAR-T presently are autologous, but there is effort to develop allogeneic CAR-T, also called off-the-shelf CAR-T. But essentially, a patient's T undergoes leukapheresis. Their T cells are removed and sent to the lab, where a modified virus genetically modifies the T cells, and the T cells are then engineered to express the chimeric antigen receptor, thereby essentially training these T cells to target the tumor cell. In the lab, the T cells are allowed to multiply into the millions. They're shipped back to the hospital, and the patient then undergoes lymphodepletion, usually with cyclophosphamide fludarabine, similar to bone marrow transplant. And then millions and millions of the patient's own CAR-T cells are infused into the patient. And again, this is for the autologous CAR-T, which are all the FDA-approved CAR-Ts right now. So what happens after this infusion? Well, the CAR-T cell then makes its way towards the tumor. The CAR, the chimeric antigen receptor, then recognizes the tumor because that's how it's been constructed. And this causes death of the cancer cells and release of further tumor antigen, which further recruits the rest of the immune system, leading to more cancer cell apoptosis. And in fact, about 10 years after the first infusion, there's been case reports of circulating CAR-T cells. And that's why this therapy is groundbreaking and has been given the name living drug. Understandably, there's been a lot of positive media attention about this groundbreaking therapy. with, on the right here is Emily Whitehead, the first ever CAR T recipient. She's 10 years past her infusion date, whereas previously she had a relapsed refractory leukemia for whom the prognosis was months at that time. So truly groundbreaking. These are the FDA-approved CAR T. They were first FDA approved in 2017. They can either target CD19, which is usually treating ALL or non-Hodgkin's lymphoma, or they can target multiple myeloma. So let's talk about recognizing common adverse events after CAR T. And this is focusing generally on what all patients experience, not just cardiotoxicity. So here's an image of the FDA label for one of these CAR T products. And what you can see are there's two main toxicities listed. One is cytokine release syndrome, which we will talk about. And the other is neurotoxicity, also called ICANS. And ICANS is treated with steroids, time-wise, roughly overlaps with CRS. I will not go into ICANS because really the neurologists are called to manage this. But I will go into cytokine release syndrome. So CRS is essentially three symptoms: fevers, hypotension, and hypoxia. And the degree or the grade of CRS depends on the severity of hypotension and hypoxia. Now, obviously, if you're giving a patient antipyretic or they're on steroids, then the fever is no longer part of the criteria, and you just rely on hypotension and hypoxia. And it all goes from just needing nasal cannula to be intubated or needing multiple pressors. That decides the grade of CRS. And how do you treat this? Well, it's steroids and an IL-6 receptor antagonist called tocilizumab, which are used to mitigate the efficacy, mitigate the severity of the cytokine storm. And particularly in terms of tocilizumab, that does not seem to limit the effectiveness of the CAR T. So now let's dive into the cardiovascular effects of CAR T. We'll start with a case. This is a 75-year-old male with relapsed refractory DLBCL who presents with dyspnea on exertion. The patient had been treated with tisagenlecleucel, also called Tisacel, this is a CD19 CAR T, and on day 12 post-infusion has grade 4 cytokine release syndrome because he's febrile, he has hypoxemic respiratory failure requiring intubation, he's hypotensive requiring norepinephrine, and is actually given tocilizumab. This was our echo that we obtained on this patient on the left before CAR T, normal EF, trace small pericardial effusion, but overall okay. And 12 days after CAR T, the BNP is significantly elevated at 1,000, troponin is 800, and the EF is severely reduced, as you can see here, and he has a large pleural effusion as well. So when the first CAR T data came out in the New England Journal, appropriately, they focused on oncological outcomes and said, some of the side effects are hypotension. So we asked, well, what's the cardiovascular side of all of this? And this is a study we published from the FAIRS database, where we asked the question, is there over-reporting of cardiotoxicity among CAR T recipients? And what we found was among AFib patients, there was a nearly fourfold over-reporting of cardiovascular events, and for ventricular arrhythmias, threefold over-reporting of cardiovascular events, cardiomyopathy nearly fourfold, and cardiogenic shock twofold. Here in this Euler diagram, you can see very nicely that the cytokine release syndrome nicely overlaps with cardiovascular events, suggesting there is a role of the profound inflammatory state that occurs after you give a patient millions and millions of their own T cells back in one go. And this is a core diagram that shows the overlap between cardiomyopathy, pericardial disease, and cardiogenic shock with CRS, showing that inflammation clearly plays a role here. So what's the proposed mechanism of CAR T-related cardiovascular events? You could bucket them into on-target, on-tumor, on-target, off-tumor, and off-target, off-tumor. So on-target, on-tumor is the CAR T doing its job. It's leading to the production to cytokine release syndrome and the production of interleukins, such as IL-6, which are can cause negative inotropy and cardiomyopathy. You can have endothelial dysfunction with profound fluid shifts, leading to volume overload and perhaps heart failure, or there's tumor in the myocardium and the CAR T is doing its job and is in the myocardium, and perhaps you have myocarditis. You can also have on-target, off-tumor effects. And this is where it's very important that when manufacturing a CAR T, you have to be absolutely certain that the biomarker you've selected as a target is only expressed in the tumor, because suppose it's the biomarker is also expressed in the liver, well, the CAR T cells are going to go to the liver and cause apoptosis. And then finally, you can have off-target, off-tumor. This can be quite devastating, has been demonstrated in the past. So there was a MAGA3 CAR-T that was given to patients, leading to fulminant myocarditis. Patients required immediate mechanical circulatory support and still died. And what they found on autopsy is that the CAR-T was cross-reacting with titin, which is, of course, expressed in the myocardium, leading to fulminant myocarditis. So we run a multi-center registry. It takes a village, over 500 patients who are in the registry and receive CAR-T. And so let's talk about the cardiovascular events that can occur after CAR-T. This is one of the first efforts from our registry, almost 140 patients getting FDA-approved CAR-T, in whom we did retrospective cardiovascular event adjudication, cardiomyopathy, meaning an over 10% drop in EF to less than 50, clinical heart failure, arrhythmias, cardiovascular deaths, and we found half the patient had CRS, and most required tocilizumab. And for the first time, we provided event rates. What we found was that about 12% of patients had cardiovascular events, and basically all occurred in patients with so-called high-grade CRS, meaning 2 and above, with the median time to onset of roughly 2 to 3 weeks. What about cardiomyopathy in general, in particular? So this is a nice study out of Dana-Farber, where they looked at nearly 200 patients who all had a baseline and follow-up echo, and they used the same criteria that we did. They showed a cytokine release syndrome rate of around 80%. And what they found was that there was a 10% occurrence of cardiomyopathy. And the majority of these were all new, and nearly all occurred in high-grade cytokine release syndrome. Amongst patients who did have a cardiomyopathy, there was a 21% decline in EF as a mean. And this cardiomyopathy occurred in around the 13-week mark, which makes sense. Cytokine storm usually occurs in the first week, and it's in the second week you start seeing these cardiotoxicities. Half of these patients developed heart failure. Some required pressors and intubation. And then you can ask, well, how did they do long run? Well, at 6 months follow-up, half had a complete recovery in their EF, but a quarter had only partial recovery, and a quarter had no recovery at all. This has been further confirmed in prospective studies, a really great study out of University of Heidelberg, in which they prospectively followed patients. Over time, including in our registry, we're seeing that outcomes are improving, similar to what Dr. Sandler showed, that for the fatality rate for ICI myocarditis has improved. We're also seeing less cardiomyopathy and heart failure because of greater awareness on how to manage these patients. So in a recent contemporary study, they found a 3% cardiomyopathy rate, but also nearly 10% occurrence of fluid overload. So now we've established that cardiovascular events do occur in the real world. This includes cardiomyopathy and heart failure. But how about heart failure? How about arrhythmias, atrial arrhythmias? So this is another study that we published from our group. We looked at the FAIRs again, just asked the question, is there over-reporting of atrial arrhythmias in CAR-T recipients? And what we found was that when you compare CAR-T recipients to the entire FAIRs registry, there is a 4-fold over-reporting. And if you look at just cancer patients, also 4-fold over-reporting of atrial arrhythmias. So clearly there's something going on. And then we looked at our registry, nearly 240 patients, and found that 10% developed atrial arrhythmias, half of which were de novo, and most required medical intervention. So a clear overlap between this pro-inflammatory state and atrial fibrillation. Contemporary prospective studies have also similarly showed a 5 to 4% rate of de novo arrhythmias, similar to what we found. We've also elucidated the biomarkers associated with those who are going to have atrial fibrillation. Not really clinically applicable yet. We're developing risk scores. But then more importantly, we asked if the co-stimulatory domain matters. And turns out that if you're getting a CD28 CAR-T, nearly 5-fold higher occurrence of atrial arrhythmia. And there's clear data to show that CD28 is far more pro-inflammatory than 4-1BB. You could ask the question, can you give lysocell to certain patients, which is 4-1BB co-stimulatory domain, if they're high cardiovascular risk? And that's really a question for the oncologist to make. Okay. Myocarditis, well, there's some limited data, case reports primarily. As in the last few minutes, just wind up by saying that for multiple myeloma CAR-T, roughly similar occurrence of cardiovascular events. Okay, and so there's meta-analysis data to show that if you sum it all together, less than 10% occurrence of LV dysfunction and atrial arrhythmias in this population at a median follow-up of 1.5 years. But look at this all-cause mortality, nearly 30%, because they're still very sick patients. Okay. There's also data from our group showing that if you have a severe cardiovascular event, clearly associated with mortality as well. So these events matter. They do impact survival. So how do you manage these patients? This is all anecdotal at present. The ESC guidelines say get baseline troponins, echo biomarkers. Our practice is we do close volume management. We actually follow all these patients on our inpatient cardio-onc service, and we do echoes about 3 weeks later, and we have a low threshold to give CAR-T. We'll also see these patients before CAR-T. Again, all anecdotal, we use this criteria. If you're above 65, history of MI, arrhythmia, cardiomyopathy, or moderate to severe valvulopathy, or multiple cardiovascular risk factors, you warrant us to come and see us. And then we do a baseline EKG and echo, volume optimization, and everyone gets an echo at the 3 to 4 week mark. And then a word about tocilizumab. From our retrospective data, every 12-hour delay in giving toci was associated with 2-fold increased cardiotoxicity. Again, IL-6 receptor antagonist doesn't reduce the efficacy of CAR-T. Again, this is retrospective data, but for my practice, we have a low threshold to give tocilizumab to turn off the inflammation in these patients. So I'll conclude by saying CAR-T has improved survival despite the relapse refractory malignancies. Arrhythmias, cardiomyopathy occur in up to 10% of cases. Severe cardiovascular events do worsen mortality, so there's an opportunity for cardio-oncology to improve this. And early use of tocilizumab may reduce cardiotoxicity, but this is all purely retrospective data. We run a journal club online every month that we have people from all over the world who present. So I would invite you to log in and see some of these topics that we cover. And then finally, thank you for inviting me. And then more importantly, we're in New York and we're hiring. So if you have an interest, here's my email. Please reach out to me. And thank you very much.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.
Free audio post-production by alphonic.com.